So, Dr. Friedman, the world of migraine symptoms is full not only of the obvious, but also the unusual, the rare, and sometimes the bizarre. So maybe we could start with a brief overview about why there are so many possible symptoms that are associated with migraine.
So the short answer to that question is migraine is a brain disease. And people think of migraine, obviously they think of headache, but migraine really affects almost every part of the brain. And so we do see a lot of very unusual symptoms, unusual patterns. And to me, it's one of the things that makes migraine so fascinating. So I'm not sure that people who have bad migraine would consider it fascinating, but to me that's one of the things that really makes it so interesting, and it's different from person to person, and even within a person, from episode to episode. So it's your whole brain's involved.
Yeah, that's really interesting. And I know that one of the things you mentioned was about the hypothalamus being involved in migraine symptoms. And so maybe you could just mention a little bit about what we were talking about before this event.
Okay, so I know that there are questions about the prodrome phase, right? Or what we used to call the premonitory phase. And that is thought to be caused by activation of the hypothalamus. So the hypothalamus, it lives pretty close to our pituitary gland and right under the thalamus, hence that's how it got its name. But it does a lot of really interesting things. So it controls, it's part of what controls like hormonal patterns. It controls the timing and the circadian, the daily rhythmicity of a lot of the functions that the human body has. It controls hunger and thirst. It controls mood to a large extent. And it also controls sexual function and sex drive. So the conversation that we were having before this started, as I was thinking about the hypothalamus, in preparation to speaking with y'all today, was, nobody ever comes into my office and tells me that during prodrome they get horny, right? I mean, does this happen? Doesn't it happen? I'm not really sure, but why would that part of the hypothalamus get left out of the party? I don't know. So maybe we should take a look at this and see, if there are effects on sex drive during a migraine prodrome. It's probably not high on the list of things that people would come in and want to talk to their neurologist about.
Yeah, I mean that's tough. I know that I don't think it's ever been brought up in any of my conversations with any of my headache specialists, but patients do talk about this generally in private off social media. But just to let everybody know, this is something that Dr. Friedman and I are talking about, maybe doing a survey or something together just to explore it. So, keep that in the back of your mind that, it's hard to talk about sex when it's to do with migraine, but it's obviously very pertinent, and it affects, most of us in some way or another. So we're going to have that conversation as well at a future time. So one person wrote in, prior to the onset of pain, they have symptoms like extreme tiredness and frequent urination. Have you seen this in that prodrome or premonitory phase of migraine?
Absolutely. So in the prodrome phase, the most common things that we see, and there were a lot of questions about this, hunger, food cravings. I know there are questions about how do you know it's prodrome or, it's a trigger. We can talk about that too. But food cravings are also very common. Unexplained mood change, one way or the other, right? So either people they feel down for like no great reason at all, or they get just euphoric, right? Lots of energy, euphoric, which is really kind of one of Mother Nature's cruel jokes, because that means you're going to get a migraine afterwards, you're going to get a headache. It can cause excessive thirst, excessive urination. Sometimes people will experience some of those migraine headache symptoms as part of their prodrome. Sensitivity to light. A lot of people, they know that's how it's coming, is because all of a sudden the lights seem too bright. Sensitive to light, sensitive to noise, sensitive to smells, just a whole host of kind of strange things that often people don't pay attention to, or they don't make the connection that this means my migraine's coming, right? Because these things can happen anywhere from, a half an hour before the headache starts to a couple of days before the headache starts. So sometimes it's really hard to link them together.
Yeah, that's really challenging. And just in case folks are wondering, and I should have mentioned this, we're going to be going through symptoms phase by phase. So we're looking at the prodrome phase, then aura, then attack, postdrome, and then we're also going to talk about interictal, which is in between the attacks. And so this prodrome phase is really fascinating. And what you said, Dr. Friedman, about trying to figure out what's causing what's actually going on in that phase is hard because a lot of people are unaware of what's going on. So for example, like I get high energy before an attack. And I used to think it was because I did too much that I would then get an attack. But now I recognize that's my prodrome, right? So
Exactly.
How can people figure out, going on the opposite end for chocolate, do people crave chocolate during prodrome? Is it really triggering it? How do people determine what's a trigger and what's actually just part of their prodrome? In other words, enjoy it.
I was thinking about this too, because I love chocolate. So I think it's one thing to crave chocolate, like I really have to have chocolate like right now. Where is it?
Right.
Versus, oh, there's some chocolate sitting over the candy dish, and maybe I'll have some of that. Okay,
Right.
that's not a craving. So if you get a migraine after unemotional chocolate eating,
right,
then it's probably a trigger, and it is really a trigger for some people. But I think for a lot of people, they actually get the craving.
right. And that's interesting.
So
And that's
it's not
probably just being aware.
chocolate. It's I
Right.
gotta have chocolate and I gotta have it now.
Right. I'm a
I feel that way
chocoholic.
most
So
times, actually.
yes, I mean, I just want chocolate whenever it's around. I'm going to want it, but I understand the difference between a craving, right, where you just really have to have it, kind of similar to a pregnancy craving, right, where that's just what you want.
I guess.
Maybe I don't know. It's like I craved weird things during pregnancy, so I craved weird things during migraine as well.
Do you?
Which
Okay.
yeah,
I mean, because
like
I usually don't hear about, I just have to have broccoli. Okay. I mean, people usually crave carbs or they crave salt, right?
Yes, exactly.
So,
yeah.
Something
I know
sweet
that's
and
certainly
something
true for
salty.
me. Something sweet, something salty. And I think you mentioned very briefly moods, but moods can go from all ranges during the prodrome, right? So irritability, silliness, depression, anxiety, the whole spectrum. Is that right?
Yeah, it's like, why all of a sudden is this like setting me off?
Right.
Normally it wouldn't bother me. Why am I so cranky? That kind of stuff.
Yeah, that's interesting. So it's really important to understand what happens before the actual attack, before the pain phase starts, in case for those who are watching this, track that and see if something is part of your prodrome or just coincidental. One of the more unusual things we hear about, and they don't know if this is part of the prodrome or part of the attack, but phantom smells. So what is that and how common is this?
Phantom smells, and it's a good name that y'all call it because the technical term is phantasmia. Osmia means smells. I think it's aura. And people who have epilepsy also get phantasmia. And it's called the aura of their epileptic attack, of their seizure. So this does occur. It's not common, but I certainly hear about it. Usually it's a bad smell, or some people describe burning. I smell something burning. It's like cigarette smoke.
Right.
I've had a phantasmia of tuna fish. Like somebody ate tuna fish.
Interesting.
No tuna fish. But I don't know. Maybe it's just me. I don't get a headache after the tuna fish smell. It just makes me want to have tuna fish.
Okay.
Anyway, according to the definition of aura, and we'll get to aura, but aura has to be a reversible focal neurological symptom that comes from the brain. Okay, that's what aura is. And the sense of smell, it's part of the brain. So I think it's aura. The other thing is aura has to last between 5 and 60 minutes. And I don't know, again, when thinking about phantasmia, how long that usually lasts for most people. Like the tuna fish for me doesn't last that long. But I think for people with aura, that smelling the bad smell of the cigarettes may actually go on for a while. But I would put it in the aura phase. And the only other thing I want to say about this whole phase thing is that we like to compartmentalize the phases. Whenever you see a drawing of aura phases, it's here's the prodrome, here's the aura, here's the headache. They're not compartmentalized. There's a huge amount of overlap between all these symptoms and all these phases. So I think it's kind of artificial in a lot of ways, although convenient to divide them up into phases.
Yeah, absolutely. I remember reading something about that, or maybe I heard it at one of the AHS conferences where they were talking about these phases that, again, we like to put things in a box, as you say, but it's not as compartmentalized as that. It helps us have a better kind of understanding, but as long as we don't say, oh, that couldn't be happening because that belongs in a different phase, then that's probably better. So talking about aura, so we covered I'm not even going to try to say it, phantom smells. And people, when they think about aura, generally they think about a visual aura as in like flashing lights or like gray clouds, but aura can go beyond that, right? So for example, Alice in Wonderland syndrome and some other forms, what would be all the different things that you would classify into that aura phase symptoms?
I'll probably forget some. So in visual aura, there's a list of probably 20 different things that can happen just with vision. People can, so the three most common types of aura are either visual, somatosensory, tingling, numbness, or speech and language. I know somebody asked about speech and language, but those are the three most common. And I don't know, do you want me to go through these like one at a time, or
yeah, that would be great.
What do you want me to do?
No, I think it'll be wonderful to go through them. Yeah.
Okay, vision. Blurred vision is very common. I don't consider blurred vision to be aura because blurred vision doesn't come from the brain. Blurred vision comes from your eyes and usually from the tear film. And so as one of the autonomic phenomena that occurs during migraine, sometimes people get tearing, a little bit of tearing. Sometimes people can get the opposite, they get dryness. And either one of those things can cause blurred vision. So I actually think that blurred vision is an autonomic phenomenon, it's not aura. And I'm not the only one that thinks that. But okay, so the C-shaped shimmering thing, right? The expanding shimmering thing that moves across your vision with the area inside that you can't see, the scintillating scotoma, right? Losing half of your vision. And that one usually comes on suddenly. Most aura symptoms come on gradually, and actually that's part of the definition, but homonymous hemianopia, which means losing half of your world, that comes on quickly. Sometimes people will completely lose their vision. That comes from the back of the brain in the occipital lobe. Vision may get black, vision may get white, but they just lose their vision. Heat off the pavement, you know what I mean? Kind of that wavy, shimmery kind of, like it's a hot day and it looks like a mirage off of the concrete or off the asphalt. Heat off the pavement, very common. Formed hallucinations are not very common. You know, like hallucination is seeing something that's not there. So the flashing lights, the zigzag lines, the dots, all that stuff, that's considered a type of hallucination. But like seeing people that aren't there, animals that aren't there, that typically does not happen. Upside down vision, that comes from the back of the brain, from the medulla in the brainstem, that all of a sudden everything just goes upside down or everything tilts 45 degrees. That's very unusual. Like the only things that cause that are migraine and TIA or stroke. But migraine is a much more common cause of that. You mentioned Alice in Wonderland syndrome. Things are too close, too far away, too large, too small, or even the sensation, it's not really visual, that you are, you know, body dysmorphism, you are too large, you are too small. Right? That can happen too. Isn't migraine fun?
It's a lot of fun. It really is. Honestly, I think it's fascinating.
It is. It's not fun, but it is interesting.
Yes.
Loss of color vision, like all of a sudden just seeing things like on a black and white TV.
Interesting. I haven't heard
that's
that
a little strange too, right? That also comes from the occipital lobe. I think I hit most of them. If you can think of one, let me know.
Yeah. No, I think that's great. I love that. And I used to get teleopsia until very recently. Everything was like super,
Too
super
far
small.
away.
Yes.
Yeah.
And I thought it was normal until someone eventually explained to me what was going on. But yes, I would sit and think, does this person
Yeah.
know that they look really tiny to me? It's bizarre. It's bizarre going through it.
Yeah. Micropsia is too small. Telopsia is too big or too
Okay,
far
so
away.
micropsia. Right,
Um,
exactly. So they're too far away. Yeah.
So
Interesting.
yeah, all this funky vision stuff. Somatosensory, that's probably the next most common.
Right.
Tingling, or actually true numbness, just can't feel it, right? And often this travels. So that a classic pattern is tingling in the fingers, it works its way up the arm, it goes into the neck, it goes in the face,
Right.
and often changes sides. And that's very reassuring when it goes to the other side. The strokes don't do that, right? And strokes usually strike. Strokes happen, boom, all of a sudden I got numb. So that can also happen. You know, phantom sensations, I think those can happen too. You know, it feels like my skin's burning. It feels like my skin's itching. That's not common, but it can happen as well. Speech and language, usually it's either slurred speech or just trouble coming out with the correct words, right? Not being able to producing words that don't make any sense, not being able to string a sentence together. Trouble understanding language is much less common, okay? We rarely hear about that with migraine. So I could understand everything, but I just couldn't get the words out.
Right. Are the speech changes predominantly during the aura phase, talking about, compartmentalizing, or do you see that throughout the attack phase?
Well, that's the thing. Like aura symptoms often occur during the pain phase, right? During the headache phase. So they may start in the aura phase, but they can persist during the headache phase for sure. They can last a long time.
Yeah.
And aura, even though we give it an hour, it's an hour per symptom. And symptoms usually come sequentially, right?
Okay.
So I had the visual thing, then I felt, the tingling, then I couldn't get the words out, then, whatever happens. Motor symptoms, weakness. So you can have weakness on one side, you can have weakness on both sides of the body at the same time, which is called hemiplegic migraine.
Right.
So we call it hemiplegic migraine, but you can have weakness on both sides of the body at the same time during migraine, and that's kind of a special kind of migraine. What else? Just vestibular stuff, right? That kind of goes in its own category too. Dizziness, ringing in the ears, muffled hearing, all that kind of stuff. People can also get, as part of migraine, trouble with their balance. People asked about double vision. That comes from the back of the brain. Absolutely, people can have double vision during migraine. Not common, but it occurs. What did I miss? Trouble swallowing, not common. I wouldn't put that on high on the list. I'm trying to go through my whole list of what happens in different parts of the brain. But there are just so many neurologic symptoms that can occur. We've even seen, actually, I wrote a paper about it, hiccups as a migraine aura.
Yeah.
And that comes from the back of the brain as well.
Interesting.
So, yeah.
Where would yawning fit into all of that? Because we know that yawning can also be a sign that an attack is coming on as well, right?
Yawning is a prodrome.
Prodrome.
It's quite specific for migraine, uncontrollable yawning. Other things can cause it. Like for me, it was working in front of the electronic medical record. I couldn't stop yawning.
That can happen. Right.
And I'm like, oh, am I going to get a migraine? No migraine. It's the electronic medical record. It destroys all of us. Anyway, but yeah, it's a prodrome.
Okay, interesting. What about, do you see in the prodrome or aura phases, do you see changes in heartbeat, as in a really racing heart or palpitations? Have you ever heard of that happening to people?
Well, that's part of the autonomic nervous system. So I have no doubt that it can happen. Just like some of the other weird things that are part of the autonomic system, like, the bloodshot eyes, tearing, droopy eyelids, swelling. I have no doubt it can happen.
Yeah. And it's interesting you mentioned that because things like teary eyes, drooping eyelids, runny nose, they're often associated with cluster headache or other attacks, but actually they are often seen in migraine attacks as well, right?
Yeah, they can be. Now, the tearing in cluster is usually much more dramatic than the tearing of migraine. In cluster, people just have the tears are pouring down their face, right? And typically with migraine, you're a little teary.
Right.
So,
Okay.
and it's usually
Good.
both eyes for
It's
migraine.
a little
Not
different.
always, but usually.
That makes
So,
sense.
but there's a
One
lot
of
of
the
overlap.
Yeah, which can make it challenging. One of the questions we had from someone this week is they said that they get joint pain, body aches, hot flashes, sweating. This is during the what we call the attack phase, but really we're talking about the pain phase of
Mhm.
it. So is that something that you see a lot?
I wouldn't say I see that a lot, but it can certainly happen. Again, some of that stuff is part of the autonomic nervous system. It's the sweating is probably hypothalamic. People can even run a fever during migraine. People can go into coma from migraine, right? Coma is not hypothalamic, but it can be a part of migraine. I remember when I was an intern, there was this patient that used to come in maybe every 6 months or so in coma. And it turns out that it was from migraine.
That is
I was pretty blown
fascinating.
away by that.
Interesting.
Um,
It highlights
the
how serious migraine can be, right? And how
Yeah,
complex it
for
is.
sure. What was the other one that they mentioned? Oh, joint pain and body pain.
Right.
So it's more common in children. I have seen it in adults. I have heard about it in adults, but kids with migraine will often get joint pain and body pain. Not sure why.
That's interesting. It's interesting. It's different with them. Now, what about ringing in the ears? Or tinnitus? Hopefully, I'm
Tinnitus can
pronouncing that
happen.
correctly. Yeah.
Absolutely.
Is that a fairly common symptom? Because increasingly, I'm hearing from people, "Oh, I get this as well," and
Yeah.
I didn't know about it till recently.
Yeah. On the spectrum, I guess I would put it in the not that uncommon. I
Right.
mean, we hear about it.
Okay, that's
It's
interesting.
not
And then
like
we all
coma. Okay.
right,
Coma's
not like
pretty
coma, which is
uncommon.
rare. Okay, well, thankfully. And then we already mentioned blurry double vision as a symptom. One of the questions we had was, for people that have status migrainosis, sometimes they find that their symptoms kind of develop. I know for myself, I get blurry vision and it gets worse the longer it goes. But my sense for what you said earlier is that that could be because the eyes are getting drier or some other change in your eyes. Is that correct?
Yeah. I think that's another one of the autonomic nervous system
Yeah.
pieces.
Which can be obviously very frustrating. We already covered speech changes, so aphasia. A lot of people were asking about slurred speech and about speech changes, just kind of sounding gobbledygook coming out instead of what they really want to say can be really frustrating. Do those speech changes tend to slow down during the pain part of the headache, of the migraine, or can they
Not
can appear
necessarily.
whenever, random?
I mean, they're going to leave when they decide to leave, really.
Right. Yeah. And then, of course,
And
during this phase,
obviously, the whole cognitive thing, right? Not being able
right.
to think straight. I mean, that's a huge part of it, too.
Absolutely. Yeah. And I didn't even write this down there, but that's important. Did I miss anything from the attack portion or the pain portion of the phase? Obviously, other than pain, maybe we should talk a little bit about pain, because when we go to our doctor's offices and sign documents and fill them out, they often say, is it pounding? Is it, stabbing? Is it, it can be very hard to define what the pain is like, but maybe we can talk just a little bit about that.
I mean, first of all, you don't have to have pain.
Right.
Right. You can have migraine without ever having pain. You get aura symptoms and prodrome symptoms, and you may not have pain at all. But that's how we diagnose migraine. It's part of the diagnostic criteria is you have to have pain, and there are, certain things. It's like a menu, right? 1 of 4, throbbing or pounding,
Yes.
lasting between 4. It has to last at least 4 hours in adults and last 2 hours at least in children, ending within 72 hours, or then we call it status migrainosis. Throbbing or pounding, one-sided, worse with routine physical activity, which to me is probably the most important one of the 4, right? And moderate to severe in intensity. So, not everybody has headaches that are one-sided. Not everybody has severe headaches. But usually, with rare exceptions, people, if they had their druthers, would want to go lie down and not move. And I understand in real life that doesn't always happen. You can't always stop what you're doing. But given the choice, it gets worse the more you try to function with it.
Yeah,
so
absolutely. That makes sense. I just want to back up a little bit because I saw that the question came in, and just to remind anybody who's come in since the beginning that we are taking live questions. So if you have questions, please put them in the comments. I have someone feeding those questions to me so that I can ask them of Dr. Friedman. And this is a question they're asking: can fainting be part of a migraine aura?
Haven't heard that. No, I don't think it's aura. Losing your vision maybe, but not, I don't know. I've never heard that as an aura symptom.
Okay.
I would think that would be more of an autonomic nervous system thing.
Okay. Okay. So that's the answer to that question.
Sound good, though.
Yes, that's a new one for me. I haven't heard that. Going on to Postdrome, but thank you for asking that question. I really appreciate it, because there are so many symptoms that are associated with migraine that it's easy to miss something out or presume that it's not, and actually it is. So
before we go to Postdrome, actually, if you don't mind.
Yes.
Sorry.
Oh, absolutely.
No, we didn't hit on the big ones: nausea and vomiting, right?
Of course.
Sensitive to light, sensitive to noise, sensitive to smells, nausea, vomiting. Nausea and vomiting can also occur during the premonitory phase, right? And often when I interview people, they don't really distinguish between nausea and vomiting. So, do you get nauseated? Oh, no, I don't vomit. Nausea is not vomiting, right?
Right.
And I don't mean to insult anybody, but nausea, it's like, do you get queasy? Do you have an upset stomach? Do you just like, I don't feel good, I don't want to eat? Okay, that's nausea. Or I feel like I'm going to throw up, but I haven't quite done it yet. And nausea counts just as much as vomiting for making the diagnosis and for the treatment.
That's good to know. Yeah, I know for me, my earliest symptom is nausea. Actually, nausea, my heart races. And then I know that it's I'm about to have an attack, or I'm really already in the attack, because it's prodrome. So yeah, it's very important, like you say, to differentiate between nausea and vomiting. And nausea can be just as debilitating as vomiting.
For sure. I have a lot of patients that their nausea vomiting is a lot worse than their pain.
Yeah.
And it's important to make sure you bring that up so that you will get treatment for your nausea, which I think often is not done. Yeah.
Absolutely. And it can impact the types of medications that are going to work for you, or the method of administration as well. So very important to talk about it. You did, of course, talk about, I just kind of presumed these, but I shouldn't. We're talking about light sensitivity, sound sensitivity, smell sensitivity. Could you just talk a little bit about each of them? Allodynia is a big one. So yeah, maybe you could just go over each of those in turn, just so that we have a little bit more clarity for people who are watching this.
Yeah. Okay. I mean, light sensitivity is just what it sounds like. All the lights seem too bright. They hurt my eyes. They make my head worse, the head pain worse. Same thing with, and that can be a trigger as well. Or maybe it's the premonitory symptom, who knows? Noise, same thing. Can't stand the noise. I can hear, a pin drop a mile away, which is not just I can't stand the noise, but a very heightened sense of hearing. What else? We talked about smells, and then allodynia. So allodynia, things that shouldn't normally hurt. And the most allodynia is what we call cutaneous allodynia. It affects the skin. So, having to take off jewelry, take off your clothing, don't touch my head, can't brush my hair, all that kind of stuff. And we'll get to the postdrome, but that often persists into the postdrome as well. Yeah, that can occur anytime during the migraine.
Anytime.
And in between the migraine.
I was going to say, and in between as well, we hear from a lot of people. So yeah, allodynia is a big one that people bring up. And I know that with light sensitivity, sometimes it can be so severe that even a tiny bit of light causes pain. It can be really, really extreme. We had a question about aura, so we're kind of floating around a little bit. Someone, and it's kind of slightly off topic, but not exactly, is there cause for concern if your aura changes during an attack? I guess from one type of aura to another. Not exactly sure if the person wants to clarify that, but that was the question.
Migraine changes throughout life, okay? And it's very disconcerting when this happens, right? Because people are used to this progression that for many people, it's always the same, right? But it's not always the same.
Right.
And there are a lot of people that get different symptoms during different attacks, or they come at
Right.
different times during the attack. And especially with women, for women, with hormonal changes, during pregnancy, things can change. During menses, things can change. And, perimenopause and menopause, things can change. And that includes aura. And so for many people, men and women, or whatever also falls into that general category,
Right.
I don't want to be like, leave anybody out. But it's common as we get older for the aura symptoms to persist and the headache to go away. Right.
Right.
So, and that really, I've had patients that, they were so used to having aura and then having this horrendous headache that it triggers an immense amount of anxiety when they get the symptoms, even though their headaches are going to go away. They still get the aura. But it does change throughout life, and it can certainly change from attack to attack.
Right. Okay. So hopefully that answered your question. If you want to amplify that, then please let us know. But yes, I think that's really important to note that not all attacks are the same. They change throughout life, change attack to attack. So migraine is complex. And just when you think you've got it down, I always say migraine is like artificial intelligence. It knows you and it's like, aha, gotcha. I'm going to switch it up now, but that's just my own thing. Are we ready to go into postdrome? Do you think we've pretty much covered all the other phases in general? Probably
now.
Right now.
Yeah, for now.
Right. Okay, that will work for now. So in the postdrome phase, which again, a lot of people don't realize, they think it's just all about the aura and the pain. What happens in that postdrome phase immediately after the pain has gone?
Right. So, some people consider like it's their hangover, it's their wind down. There's a lot of names for this. But I would say that probably for most people, it's not like the migraine's gone, okay, I'm back to normal, right? And so there may be a little bit of residual pain, tiredness, feel like I've been hit by a truck, cognitive dysfunction that persists. What else is a big one during postdrome?
Mood changes.
Residual light sensitivity, residual nausea. I mean, just anything that happens in the headache or any phase of the headache can persist afterwards. And
do you see depression and
a day.
Right. Okay. Do you see depression and anxiety during that phase as well?
There can be, sure. And usually it lasts, up to a day or so for most people. Some people say it lasts longer. But for most people, I would say it lasts up to a day before they really feel like they're back to themselves again.
Right. Interesting. So something that's often not talked about with migraine and symptoms is this thing called the interictal period, which I love because it just goes to emphasize that if you have migraine, you have like a migraine brain, is how patients like to call it. And it's not like you stop having a migraine brain in between attacks. So there are symptoms in between the attacks as well. What would be the most common symptoms that you have seen in your practice or that you're aware of that go in between attacks?
I would say that allodynic symptoms are probably the most common. And I consider sensitivity to light, sensitivity to noise, sensitivity to smell, allodynia, right? Things are uncommon and unpleasant. They're unpleasant when they shouldn't be, right? So it's sort of like allodynia of the visual system is sensitivity to light. But even, cutaneous allodynia can also persist during symptoms. We know that the whole threshold for having migraine in the interictal period, that doesn't go away, right? So, we're paying a lot more attention to the interictal period.
Yeah.
And we're finding things on like functional MRI that are still present in the interictal period. And I think you'll be hearing a lot more about it.
Yeah, that'll be interesting to know, which kind of brings me on to my next question, which is, have you seen that symptoms change as migraine disease progresses? So a little different than symptoms, can be different during each attack.
Right.
But for example, as you chronify, do people get more of one type of symptom? Do they just tend to get worse? Do they get more symptoms, or does it vary?
You mean as migraine progresses, like gets worse, like from episodic to chronic, that kind of thing?
Exactly. Yes.
I don't know so much that they change, I don't know if anybody's really ever looked at this, to be honest.
Yeah.
I don't know so much that they change. I think that certainly the whole allodynia aspect of it gets worse, that they never, for some people, they just don't go away like they should,
Right.
even between attacks of pain.
Right.
But as far as
Interesting.
like developing new symptoms, everybody's different. I don't
Right.
hear that much.
Hard to put us into a box.
Yeah.
One of the questions that we had before, and we just got asked it again in the chat, is because this is such a hot topic in the migraine community about medication overuse headache, or like we prefer to call it medication adaptation headache, also known as MOH, also known as rebound headaches, depending on who's listening. So the question is, how can I determine if I'm having a true migraine attack or if I'm having a medication adaptation headache?
I like the term, by the way.
Thank you.
We're always trying to think of new terms for this because nobody really likes medication overuse headache. It sounds very pejorative. If I'm having a true attack, when I'm trying to get a sense for people who are, for whatever reason, taking a lot of analgesics for their migraine, because it doesn't happen if you're taking analgesics for your arthritis, is kind of the timing of the medication and the quantity of the medication. And often one of the things that I will hear is that the medication wears off, right? So it's like a continuous pattern of taking acute treatment because it wears off, right? We like to have acute treatment work, not wear off. Right. And so if you're constantly having to take stuff because it's wearing off, okay, that's a clue. Waking up in the middle of the night, right? Taking medicine like before you go to bed, and then waking up, 4 or 5 hours later when the stuff wears off. That to me is another big clue. But we always say, like, if you have to take acute medicine more than a few times a week, then we start worrying. We worry about progression of migraine, and that medication may, in some people, be contributing to that. I don't know if that answered the question, but
no, I think that's helpful because it's not necessarily a black and white thing, right?
Yeah, it's not.
It's not easy to always know. I know some doctors, they'll pinpoint anyone who has frequent migraine as having, medication adaptation headache, and the patient then feels blamed, like they're taking too much medication. But like many patients will say, how am I supposed to survive? How do I get through my day?
Exactly.
And so, that's probably a time you should probably, consider seeing either a new doctor, having a more intensive conversation with your current doctor, or seeing a new doctor, seeing a certified headache specialist if you're not already, if it's getting that complex. So
I mean, it's particularly difficult when somebody prescribed that to you, right?
Yes.
Somebody prescribed you a bottle of whatever, and when you take it and then you get blamed, it wasn't your idea.
Exactly.
Right. That doesn't make any sense.
It doesn't make any
sense. Keep in
sense.
mind, it's everything acute that you take. Because sometimes I hear, well, I only take, triptans, twice a week, but they're taking other stuff. And it's the entirety of acute medicines that put people at risk, not just one particular medicine.
Right. Absolutely. That can be hard for people to get. Yeah. I mean, triptans and butalbital and Excedrin migraine, right? If you're taking that every day as well. So it kind of adds up. Yeah. And I just want to remind people that there are a lot of new medications since 2018 that have come out. So if you're not seeing a headache specialist, they may not be aware of them all, but you can certainly come into our group. You can go into our website, migrainemeanderings.com, and you can learn about all the new treatments. We also have a list of clinical trials for products that are coming up. Just in case you are losing hope, please don't lose hope, because there is so much in the clinical pipeline. I think one thing that we have missed, and just to let people know, I've covered all the questions except for one. So if you have another question, now would be the time to put it in. Otherwise, we're going to close out in a couple of minutes. But one of the things we have not covered is facial pain. So how common is facial pain during a migraine attack?
Not very, but it can happen. It's that trigeminal nerve. So it can definitely happen. I remember one I forgot, not a pleasant topic, but diarrhea. We talk about nausea and vomiting a lot.
Yes.
But there are some people that get it out of both ends, or maybe just the other end. So
Yeah.
diarrhea can definitely be part of a migraine.
Yeah, and actually, I forgot, but someone actually asked that question. So thank you for bringing that up. I appreciate that. Migraine can be messy, and it's hard to ask about
Especially
all
if you have
the
diarrhea.
symptoms. Yes, it's not easy. So it's important to have an honest conversation with your doctor, but that can be very awkward as well. So that's why we do these videos, so that you can feel a little bit more normal if this is happening to you, and that there are other people experiencing it. But Dr. Friedman, have I missed anything else that you want to cover today that you think is important?
I don't think so. Other than I hope nobody misinterprets my smiling and joking around as that I don't take this seriously. I take it very seriously. This is just the way I naturally communicate with people. I understand what you're going through. I get great joy in treating people who have migraine, because there's a lot that we can do, and I understand like how it affects people's lives. So don't misinterpret my demeanor.
Yeah, thank you for saying that. I appreciate that. And people who know me know that I have a gallows sense of humor. It's one of the ways that I survive having almost constant pain from one condition or another. And but obviously, we know that migraine is very serious. Dr. Friedman is a world-class doctor. We hear so many good things about you, Dr. Friedman. I just want to encourage people with that. But yes, please don't be offended at anybody. Migraine is very serious. It's very complex. It is life-changing. It is often devastating to people. And we're so privileged to have doctors such as Dr. Friedman, who are part of our advisory board, who are willing to come and do these events for us so that we can reach more people and raise awareness about it. So I just wanted to say thank you so much for being with us today, Dr. Friedman. We really appreciate you. Thank you, everybody who has tuned into us today, and everybody who watches this video afterwards. Please feel free to ask questions. Please go and explore our website and all our resources. There are so many different ways that you can learn, and so many ways we can continue to raise awareness. But most of all, never feel that you are alone, because there are so many of us out there who live with this devastating disease. So thank you, everyone, for being with us today.
Thank you. My privilege.